This seems a lot more distal because it's really not over the groin and it's well below the greater trochanter, and also because it is going to the fibular head. I just don't feel like it's that same distribution. I did recheck her borders at the last session. Mm-hmm. They haven't shrunk. They're still very discrete borders, and it hasn't really shrunk in size at all. She is actually the next patient that I have coming in. So
that's good.
No pressure, but give me something to do.
Yeah. Well, that's what we're going to look at is, okay, because you're thinking, okay, if you have discrete borders on this individual, then that would be the first thing I think of it. And it's just the word discrete, which makes me think of it. Okay, do I have a discrete border that may describe that? Now, lateral femicutaneous nerve can go anywhere from the iliac crest all the way down to the lateral knee. Not maybe quite as low as the fibular head, though. So it's a broad distribution of that nerve. So that's just one thing to consider.
Okay.
I have radicular symptoms, radiculopathy. That's why we have to look at, do we have anything in the lower extremity? I'm really going to think kind of foot with that. Now, the other one would be, do I have any type of, with dural, if I have a dural irritation going on here, and we've been getting that a little bit later on with the next phase this lady went into, is that, there we have, usually, distribution will be vague. It usually covers several dermatomes, never spreads to the feet really with a dural irritation. There could be lumbar and gluteal components that also go along with it, but that poor localization would make that loss of sensation would differentiate it from a dural irritation. That's what
Hey Dave, have you ever done like a chin tuck or a neck flexion with a prone knee bend to kind of tease out that possible dural component of a femoral nerve or a prone knee test?
Yeah, I have, and it's funny when you generally find it, you kind of know it's coming. When somebody has that traction, and I've seen it in a few people. It's not a common thing I see, but yeah, that would be one thing with her. Okay, do you have a neural traction? And that's just what I'm thinking from the mechanism possibly of injury.
So trying a prone knee bend for a femoral glide.
Yeah.
To work on that mobility of the peripheral nerve, but then if it was positive and changed with neck flexion, it'd be more of a dural than peripheral.
Mm-hmm.
Okay. I did. Yeah. We added some, and she's not very irritable with that prone knee bend, so that has been part of her home exercise program now.
Good. Yeah, she's got a
I'll check the neck.
Yeah, so she's got a very interesting mechanism. That's why, for me, what I would do is try to really discreetly, can I see where the neural border is? Do I have clear borders along there? Because, with a clear border, then I feel a little more comfortable thinking, if I go back to something that's more, a peripheral traction. Now, lateral femoral cutaneous comes from L1, L2. Doesn't really go down lateral knee that far, but it's just something to consider since she has the compression fracture that high. And that can certainly come into some dural irritation. And again, it's kind of, part of this is because it gets that vague territory, it's your bias correction. So, hey, my natural thought is if I was testing this patient, I would rule that out because I can rule that out pretty quickly with lateral femicutaneous. I can map it, it's clear distribution. Katie says, hey, it doesn't really match that distribution. I don't have clear borders. It's going down into the lower leg, past the fibular head. Now I start to lean away from, okay, my H1, which was the lateral femicutaneous nerve. Now I'm probably looking at something, if I have neurological symptoms, and I know, okay, it's not really, somatic in nature, because somatic, there could be like dysesthesias with that, but I shouldn't see a discrete loss of sensation with a somatic dural irritation. Does that make sense? So now I'm back to, okay, do I have something more in a radicular nature? Fracture pattern doesn't really match a fracture. I expect acute event. We see the fracture, but it doesn't really match like a femoral fracture would be the one it would have to be if it was mid shaft. And vascular, if this was vascular, it's usually diffuse, usually worse peripherally, usually more full thickness, not discrete area again. And I just thought I'd kind of go over that because that's kind of in the back of my mind, the bias correction. So I may jump. My jump on this one was the lateral femicutaneous. I can rule it in or out quickly. And in my mind, I can make up a mechanism of traction with an obese woman with a flexion, with basically a hyperextension injury potentially. And I went back and reviewed kind of surgical, where you see common these in surgeries is hip surgery. So what was the hip surgical position they put them in? It's usually a traction position which traction on that nerve is what will irritate it or give them basically a neuropraxia. But again, that's easily ruled in or out with basically just a clinical exam. So from there, again, if we say it isn't, then now I'm going to radicular symptoms, and now I got to determine, is this radicular from L5 or is this radicular from up higher in 1? What did you think, Katie?
I was just going to ask real quick, with a traction injury to that,
Yes.
would you expect to see some of that like soft tissue, like that swelling, like her thigh was bigger than the other?
The swelling
very...
can cause the traction injury. So,
okay.
So anterior thigh swellings or thigh swelling hematoma is another cause of traction injuries to the peripheral nerves. So the fact that she has that may actually strengthen. When I saw that, you put it in there, that was a little check in my box for, okay, that kind of strengthens my thought process to potentially test out a peripheral nerve lesion first.
Okay, so then what would have caused the swelling other than just the impact and the...
In the anterior thigh?
Yeah.
Tearing.
Say again?
You know, is there some form of tearing? Because if she has a hematoma in her anterior thigh, and this is on the left leg, got sheared backward, you know,
Yeah.
any number of structures that may have been torn from muscle, fascia, you know, basically you have the aponeurosis, you know, around there, depending how high it is, it's higher up. You know, are we talking about, you know, abdominal aponeurosis because of the lengthening through there, you know, around the inguinal ligament, you know, so we can be looking at a few things in there. And that's where you may get some weakness in the muscle testing. The muscle tear, I'm thinking that I can do the muscle test. See, do I have pain with resistant tests? So now I can kind of tease through the muscle. So if I saw the hematoma, I'd be thinking along those lines. Is it blood trauma? I kind of picture this woman doing kind of a split, but I have a hard time seeing it hit the ground real hard that way.
Right. But to answer your question, between L1 and L5, it's so much more vertical on that lateral thigh that the L1 coming more around the top, I guess, as I picture it as a dermatome.
Yeah, it's really high up, coming around the top.
It would be more to the L5, if any,
yeah,
if it was radicular.
Yeah, that's the L5. And that's where you'd also expect the clear L5, lateral foot, or, you know, I would expect it more, you know, medial foot, and get into the foot, back down the lower leg. I'd expect that more peripheral distribution as well. So that's why that clean upper extremity distribution kind of had me thinking, okay, is there some type of traction mechanism that may have occurred up there? Because, I mean, Chris, have you ever seen anybody with a discrete, you know, upper extremity, you know, neuropathy with an L5 disc or irritation?
No.
No. So I thought about it too, and I figured, well, okay, great. I figured you'd be here, Scar to be here. This is just something I've not been exposed to or seen, but it's not something that I commonly see.
I can't think of a case of that.
But, you know, that's why if it was somatic referral, there's diffuse achiness.
One of the things I was curious about is I'm
just muted yourself, Chris.
Sorry, I was trying to be careful, not talking over everybody. I thought the thing that jumped out at me was there was a painful and weak between L1 and L4. It said, so I'm assuming hip flexion, knee extension. But the hip has been ruled out. No fracture there along the femur. Okay. How was the hip testing? Like Faber's, Faders, Scour?
She feels really good with Faber position. She feels like that stretches a lot of where she has like that fatigue. Honestly, she complains more about with her day-to-day stuff, being a checker at a grocery store. She complains more about her right hip than her left, but I think that's going to be offloading things. But with passive motion, hip-wise, there's not much that she'll complain about. And relatively symmetrical as far as motion. I think when we really go into a lot of flexion, though, we tend to get more of the compression of the lumbar spine. So that's really where if I have her doing like on the stability ball flexion, that's what she feels limited by the most, is the compression of the lumbar spine.
what did you make of the symptoms, resolving, increasing with standing and then resolving with sitting? Did you interpret that?
Oh, the fact that she had to sit to rest it, I took that more as, I would expect that more with something that was discogenic and causing radiculopathy. To offload that axial compression. I know she has been able to tolerate, in our sessions closer to 30 minutes, whereas when she first started, it was 15 minutes of standing, and that burning, she had to sit with it. So, but I guess that was what I would expect to happen, is that sitting would relieve that pain.
Yeah, because you would think with back pain, sitting would make it worse, in a sense. If it was a discogenic back pain, sitting and standing can be uncomfortable. But usually, the worst patient I see is when they come in for an eval, they're standing in the corner filling out their paperwork. That's what I always think, oh shit, this is gonna be a long hour. Because you basically know they already have a disc.
Mm-hmm.
But not every disc is presented. They're all very different. And you can have, like, this individual has a disc bulge versus an acute herniation or an extrusion or a protrusion. So the bulges are very prevalent. That's what makes the later history kind of interesting when she goes back to work, because you have a disc bulge, and then you have her become much more acute. Then that determining the why she became more acute is the kind of interesting part as well. That's when I looked at this case kind of in two phases. We know you had the L1 fracture, and so she's done pretty well with that, actually. She's had more than 10 weeks to heal up from that and did pretty well. Was able to work a pretty good day. I'm looking for my notes that I wrote up just to see if I can pull anything else out in here.
Yeah.
Hey, have you been doing any treatment up above L1, like just through the mid and lower thoracic spine to help?
We have
Clean
been
up any
doing
biomechanical stuff up there a lot from above.
it's like manual. Probably not a ton. I'm being pretty gentle around that area. I'm doing more soft tissue now than I was doing traction. At first, traction felt really good, but then when she's been working, that seems to exacerbate any of the paraspinal muscle tone, and it's not as comfortable. But she responds really well to soft tissue, and I'm just doing very gentle above and below, but probably not up into the mid-thoracic. But you think probably if she's getting more mobility there now that she's guarding down below?
I do. Personally, I do.
Yeah.
I like the idea of doing like sliders and gliders for the femoral nerve, and then also doing some mid-thoracic mobilizations. I mean, nothing too aggressive, depending on where she's at in her healing phase, especially with her level of health. But
Yeah.
I do think that would give her some benefit, especially when she's working with rotation. Dave, what do you think about that?
No, I agree, and it's that concept of it's a really irritable area, and can I get the thoracic spine to move better, decrease irritation above it? It's going to soften up the symptoms driving down into the lumbar spine, which is kind of what you'd like to have. Plus, with this here, if you think about it, like we'll get into some dural discussion. Eric's coming in just in time for that. It's exactly it. You have a retroprolsion at L1, you have a disc bulge at L5. So, what are the dural implications that come in later on this individual? So with the gliders and sliders and what Chris has kind of recommended, may also kind of go to that. So we have the mobility, the mechanical side of it, mechanically, can I move better and dissipate forces? Then we get into the dural side of it, which if I have dural irritation, can I improve that mobility there to decrease the irritation? How you doing, Eric? Yeah.
Doing well. How's everybody doing this week?
Good.
Good. Still catching up on our case for the week, so.
Yeah, no problem. What I was going over is we're going over the first portion of it, which was the thigh symptoms. The lateral thigh numbness, can't feel pressure. I think you feel pressure but not touch. And we went over the differentials for that, talking through it. Going over dural, fracture, radicular, somatic, vascular, and lateral femoral cutaneous, irritation. Yeah. Teasing out what each one of us thought and kind of how we kind of went through that process.
Yeah. That's the best way to do it.
So that one, they were feeling more radicular. I wasn't 100% certain from what she'd given me. My initial bias on this was lateral femoral cutaneous nerve, and that'd be a traction injury along with the hematoma in the anterior thigh, or things that could cause a lateral femoral cutaneous nerve injury. So if this patient had discrete borders, well mapped out, then that's kind of where I was leaning with this. But she feels it goes down to about the fibular head, which is, it can go down that far, but it's a bit of a reach.
Yeah, I mean that'd be a bit of a stretch there as far as getting down that far, because you're getting into some of the sural areas, and when you get down that far, because you're branching off now off of the peroneal nerve, so you're getting a little close to where that would have to cut off.
Yeah.
I mean, the fact that she was an obese patient as well, that definitely could lend to a lateral femoral issue, because usually you see those patients that have that real tight waistband kind of going around the pelvic, around that ASIS, and that's another potential cause of that. Is they call them like key in the pocket injuries, where you have your keys underneath there and you get some sort of hyperflexion injury, and it compresses that as it goes underneath the head of the rectus femoris. So that would have been my first one too, because we talked briefly with Katie about it last week, I think, at the end of our session here, and that would have been my first thought too. But yeah, I mean, either way, it sounds more neurological than it does, vascular or somatic. So
yeah. So we also went into like the weakness that she found in L5. So we're just discussing, did she find it in the hip versus did she find the weakness, peripherally, like a great toe extension? Because my thought was, if you found it in the hip, L5S1, it's probably gonna be a little less specific to me, because again, there's gonna be a lot of pain inhibition going on around that region. But if she had discrete fatiguing weakness peripherally, then I put a little more credence on that as being a true L5S1 fatigable weakness that she found on the initial eval, which was before the later symptoms progressed. So we also kind of discussed that a bit of what we were seeing with that. And we're just now touching on maybe some of the dural aspects of it, where Chris was discussing, mobilizing and doing neural glides through the upper thoracic spine or through the thoracic spine to decrease some of the stress on it, which gets into, the mechanical influence from above, and also into, do we have, dural adhesions going on, which may segue into that second half when she went back to work and she noticed a sharp spike in pain anytime she stood.
yeah,
I am gonna go check her femoral gliders and sliders with added cervical flexion extension.
Okay.
And maybe check upper mid thoracic, and then I will retest hip flexion abduction today and look for any fatigability.
Yeah, I also want you to check the ankle and look for, again,
Recheck. Okay.
L5S1s in the ankle.
Yeah, I was going to say, because your thing here says, fatigable L5S1, but I'd just be curious about what musculature you actually found that was fatigable. Was it just hip abduction? Did you have hallux extension? Did you have, any inversion, any of that medial hamstrings, any of those sort of things will fall into that L5, even the L5S1 diatome.
Yeah.
All right. And then I don't know that I'll be able to hop back on before, but I will if I can.
Okay. If you can,
And do you want me to email you what I find?
Yeah, that'd be great.
Yeah.
Okay. Thank you, everyone.
No problem. We're recording it too, so I'll have it for you.
Perfect. Have a good one.
Take care. So one other thing she could have done too, Eric, she had mentioned too that she had irritation with, now being back to work, she has irritation with distraction, where previously she did well. So that was my other thought too, to get a compression distraction if it's an end plate irritation. It's a possibility. That's one of the things I look for too, is, you can do compression and then also distraction tests, which would kind of create some irritability there. So
yeah, that certainly could be. It's a weird distribution for the numbness for the L5S1 to be just on the lateral side of the thigh.
I agree.
But I mean, there's nothing to say that she couldn't have had, a secondary injury to the, lateral femoral cutaneous and that. But I mean, if that's all that was, I just expect maybe some, epineurial bruising that would probably resolve on it of its own. But it sounds like this person's been dealing with this for a few weeks now.
Yeah, and typical healing time for this with the post-surgical tractions could be 45 to 60 days, outwards of 7 months. So the traction injury like this, her time frame right now is there. What I think she has is I think there's two things. I think there's this, and when she went back to work, she's aggravated something else when she went back to work and started getting the sharp shooting pain that now goes down the leg. And those are completely different symptoms from the lateral thigh pain, just in their presentation and how they're presenting. So it's really, okay, how can I explain? Is this one lesion, or is this two, or is this one lesion with two elements? My gut on this, without testing her, would be that it's two things. That the going back to work and then having the sharp shooting pain is separate. Then it's just a matter, is that L2 or L1, or is that L5 S1?
Yeah, I mean, well, with the imaging would tend to suggest that the L5 or the L1 fracture sounds more substantial.
Yeah.
The basic broad-based disc bulge, no significant stenosis, no foraminal compression, any of that sort of stuff. The imaging stuff doesn't look too damaging there. Now the question mark would be, could they have had some sort of like guillotine lesion on the L5 nerve root, something where that foramen kind of traumatically closed down that you're not going to see on an image.
Yeah.
That could be the case. But yeah, I would agree with you that it does seem like, again, I'm still trying to kind of catch up on all the details here with it, but it seems a lot more like there's more than one thing going on here.
Yeah.
Unfortunately in the physical world, we can certainly have, it's not like somebody comes into a doctor's office and they've got, cancer and hepatitis, that doesn't happen all that often, causing multiple symptoms, versus somebody having, an L5 lesion plus a lateral femicutaneous issue, or minus a, strain of the hip flexor, or, something of that nature. Those things can happen simultaneously.
Yeah, and the thing with this is that, basically she was okay. She was able to work her shift, sat down, drove home. Don't know the length of time. But then she had, severe shooting pain down the leg. So, that's where you start framing out, okay, what's the differentiation, where she started getting severe shooting pain and down the leg is, are we now looking at, with this one, I would think either we're trying to rule out dural or radicular.
Yeah, I mean, and, the question mark for me would be just how long did it take, what was the time frame between the injury, the insult, and when the shooting pain started. If we're getting into that 10 to 12 hour range, it makes a lot of sense that it'd be an inflammatory reaction, right? You're starting to build up some of that inflammatory exudate, and that pressure starts to accumulate around the nerve. That would certainly do it. That's kind of the pathonomic thing with a disc lesion. Your typical posterior lateral protrusion is somebody feels something tweak, and they straighten up and kind of go work it out a little bit, and they get through the rest of their day, and then the next morning they wake up and they can't move. So you see that sort of thing a lot. So I mean, if it was 2 hours later, you'd worry that there was some blood in the area, potentially that would cause something along those lines. So because you need to think about what causes kind of that chemical irritation of nervous or dural tissue that quickly. Well, blood's really the only thing that can do it, outside of actual compression of the nerve, where you're actually impacting that nerve root, that nerve tissue inside the dura with some sort of foraminal compression, or some sort of disc lesion or bone spur, or something like that actually is, here's our nerve and we have something getting right into it. Those are really the only two things that can cause a true neuralgic pain. So that'd be the question mark I'd have, is just how long did it take for it to get that way? So I don't know if it's saying this thing or not.
She did drive 12 hours home. They're pretty sure of that.
Yeah.
I don't know. She lives in, she's in Wisconsin, so maybe. But it's, with this one, I would think getting in and out of the car, it's that same thing. It's kind of like, okay, what was different? She went and worked today. So, one study that comes to mind is one where they looked at kind of runners. and they look at runners and disc compression. So they saw that people ran distance. It takes about 24 to 36 hours sometimes for the disc to rehydrate. So what you'll see is an increase in bulging in the disc after distance running with the rehydration and kind of thing. So the bulge will decrease. So showing us a bulge already coming in here. So now all of a sudden, if somebody's been out of work now for 2.5 months, going back to a standing position with a mild forward flexion. So, just one thing in the back of my mind as I kind of tease through this is that, okay, is this due to the unfamiliar overuse, much like you might see in this runner who gets a disc bulge and they finish themselves off on this run, but, it just came out of the blue to them, but it's been happening for a while. That's one mechanism in the back of my mind that I think about if I'm thinking about, is this purely now, okay, she's getting acute pressure, but it goes away pretty quickly. What I have a hard time teasing through is also a dural mechanism where, we had a retropulsion of the end plate of the L1, and we have an L5, S1, posterior lateral disc herniation. Is there enough stress or irritation on the dura that now, okay, she's had 8 months of basically limited activity, and now she's going to stand and work for 6 or 8 hours? Is that enough then to get it inflamed and excited, unfamiliar overuse, and I have excessive scar tissue of these structures going on? Definitely the L1 area may bind it down, and then now all of a sudden it's enough to create tension down below. So I don't have a clear answer on it, but that's kind of my thoughts on those.
I mean, it almost sounds a little bit like a double crush issue, right? You get a little bit of pressure up at L1, not enough on the imaging for them to look at it and say, well, this thing, we have some fracturing and we need to stabilize this thing. But then you get some secondary compression down at L5, right? So, at that point, you're getting a little bit up here, a little bit down here, and where else might we end up with a little bit of, tension, compression, some sort of irritation, even going through that hip area, through that anterior hip, that maybe you end up with some secondary symptoms resulting from that. That would make good sense to me too. I mean, it's kind of a strange. It's not the way you usually recognize a double crush, where you have something, 2 spots within the spinal column, compared to having maybe something at the spinal column and something at the hip, or something at the fibular head, or something at the, one of the interdigital nerves, something like that. That's more common, but there's no reason you couldn't have that. And the idea that as she goes to stand, that you're getting more compressive force on that L1 with some of that retropulsion, and then also getting a little bit more pressure through the L5, depending on what her standing posture is. And you think about what she works at cash register. Is that what I understood?
Yeah, that's what I read.
Is it at a grocery store, or is it at like a shop?
It's a grocery store. She said she was in the express lane, so she didn't.
Yeah, so that makes sense though, because when you think about what they do is they reach over into the cart, pick something up, scan it across the thing, and then twist and send it down the belt, right? So we're looking at a lot of torsion response in that tissue as well. So L1, we know, has to be patent going up into underneath T12, right? In order to allow good rotational motion and combined rotational side bending motions through the TL junction. So if L1 no longer is structurally capable of producing those movements, or we have a fault where it's locking up, because now we have this compressive force that's essentially locking up at L1. So the forces coming up from below are now locking at the L1, L2, or T12, L1 region. Did they say, was it between L1 and L2?
It was the superior end plate of L1. So 1 and 12.
Between 12 and 1. So yeah, maybe that's locking up now, and it's not able to. We're not able to transition that load into the thorax appropriately. Because now I would say that doing cashier work at a grocery store is a significant rotational activity for them, and it's repetitive. It's substantially repetitive, especially for somebody in like an express lane, when you have somebody come in with 6 items, and it's I'm trying to get these people through as quick as I can. And you're not able to, get that load into the thorax. And, obviously age-related changes in somebody in their mid-50s, you may have more of that increased thoracic kyphosis anyway, right? So some of that sort of stuff may be kind of contributing to where they're absorbing that stress as it is.
Yeah. Just reading down my notes.
At least you think.
Mm-hmm. Yeah, because the other thing with this too is that she got, she didn't stay significantly acute for, in that acute phase for very long. It sounded like within, 2 sessions or a couple days, she was feeling much better in this session. So, I mean, that bodes well for it not being, if this was inflammatory or acutely, inflammatory, I expect her to, you may have some decreased sensitization after the visit, but she's probably not going to be significantly better in the long term. This thing's inflamed. Your inflamed disc model is what we were comparing this to. If you had a sudden extrusion or protrusion, you're going to have much more severe symptoms, and it's going to last longer. It's not going to go away like this. She's kind of stuck for a while. So you can kind of go over my mind if bias correction is really, okay, what are the other disc lesions that we may have? And I want something like this that I can maybe treat and get around and move and get this segment moving better. The other ones are kind of like, okay, we need some anti-inflammatories, and we're going to pick you up on the back end. But, that's the good sign with this. It is interesting that she doesn't like traction anymore. So that kind of sticks in my mind a bit, knowing that, okay, it was an end plate lesion before, we have disc inflammation. It goes back to even the suggestion Chris had of, probably I would then be thinking, okay, like, can I find a way into the thoracic spine? And can I work my way down to this segment gently to see, can I, if L1 is restricted, can I get L1 to, move comfortably without irritating the segment, given that we're 10 weeks out? So I'm going to look for any one of these positional techniques, maybe using, graded mobilization with a positional technique, as long as I'm not seeing any irritation and symptoms, to see, can I get L1 or L1 T12 or T12, T11, T1, L1, L2 to move better without pissing the system off.
She had
the other
swelling thigh too, huh?
What's that?
I'm just looking at Chris's comment here that she had continued swelling of the left thigh 2 months after the injury as well.
Yeah, that's kind of where I was on the hematoma, potentially also contributing to the, lateral femoral cutaneous nerve injury. It's one of the things that can cause compression of it.
Yep.
It just seemed like a long ways out. Like, I thought that would have resolved by now. And the fact she said the skin looks shiny and
yeah, she was getting local changes.
I think she said I was going back to the notes, but it said shiny and swollen. Just seemed a little unusual for 2 months to me. Injury.
Well, there is another thing that could cause compression there that she could develop traumatically. That would cause potential compression going into the thigh that could leave the skin looking shiny, would be a hernia. Because the way I understood the injury is the right leg kind of went like that, the left leg kind of went like that.
Backward, yeah.
And she twisted and fell on her butt. So that kind of hyperextension there, if she wasn't getting the hyperextension through the hip, which is probably the case, she could have had some sort of inguinal injury there that could have caused some sort of herniation. And that could certainly, because that's actually the most common cause of femoral nerve compression is a hernia. Yeah. The second most common is the surgery to correct the hernia.
Yeah.
So, as far as depending on where it is, could that get some of that lateral femoral cutaneous nerve? I think it certainly could. It'd just be dependent on where it was located. I mean, I'm not saying that's definitely the case, but if you had something like that that's also affecting lymphatic flow out of the leg, that would leave the leg nice and shiny. Interesting stuff, though. And that wouldn't resolve without treatment. That would still be there.
Yeah.
Hematoma, you'd hope would resolve, or at least would be improving. It may not completely resolve in 2 months, but it may be, it should be going in that direction. You'd hope.
It's interesting because, Eric usually mentions it. There's a good way to think about it is, the different forces on the lumbar spine in this one, that, being at the cash register, we have compressive load of standing this entire time, probably mildly forwardly flexed. We also have, basically rotary or, a shear mechanism just from working the cash register, which is the two things I was thinking. So I looked at this, I kind of then applied it in the lumbar spine. What are my forces coming in here? Looking at compression, shear and rotation. There's an element of each one with how this lady would be positioned. The interesting thing is she didn't comment on any of the thigh symptoms during her day and working day. I'd be curious if they're just constant and she gets used to it, because in PT before, she was standing down more frequently. Unless she's sitting on a stool at work and working as a cashier, she has to be standing for a much longer period of time than she was used to. So just one question is, would bending forward, detraction the nerves, so you should have less symptoms, but then I have shear forces coming into play, forward flexion forces as well, and compressive load, which is kind of why I was back to that, in a sense, do we have a double crush or dural irritation? This bulge.
Yeah. Really quick, I want to go back to, because Andrea posted a question about, if we have two issues occurring, if we have, an I'm guessing, and Andrea, you're about the two issues you're talking about. You're talking about the L1 and potential L5 stuff. How do you address, what do you address first? How do you kind of prioritize that stuff? It sounds like with this lady, the priority initially is to desensitize that, alleged dural issue, that dural tension. So whatever you can do with that, whether that involves some sort of extension routine, whether that involves some sort of deloading, those sort of things that you can do to kind of get that stuff down first. And then from a functional position, which one is giving you the most functional limitation? Are you dealing with more of a limitation of rotation, which would make me prioritize L1 and that TL junction, or are you dealing with more of a, like Dave was saying, some sort of anterior shearing, some sort of hyperlordosis or something of that nature? I may prioritize hip mobility or sacroiliac mobility and look at what I can do to alleviate the L5 pressure. Is that what you were looking for? I think she was trying to answer us, but we're not hearing you real well, Andrea, if you're trying to talk to us.
Oh, Andrea, you have no voice. Now, yeah, me too. I would look at this as two separate lesions. Just on what I have, the information I have so far, I'm pretty comfortable until I could prove myself wrong with the lateral femoral cutaneous nerve one. I would look peripherally there unless I scan it and it doesn't match it, then I would move on. And I have neurological symptoms, so now I'm on to more, not a peripheral than again, a nerve root or radiculopathy kind of referring down there. But I'm more comfortable with the lateral femoral. I think the other one is a different lesion. I think the lower leg symptoms that all came up, I think it's a totally different lesion. I think it was induced by work and changes in load. So I would treat them differently. So how do you treat a lateral femoral cutaneous nerve irritation with a contusion? Yeah, good one.
Anybody?
Yeah, and it's caused by a traction injury, which is even harder. Scar tissue is easier. Scar tissue ones you can treat, and they can do well, and they can do well even after a long period of time. Scar tissue lateral femoral cutaneous one, so I'm going to give you the easier one because I'm more comfortable with that one, is that, basically what you'll find is that sometimes like a smaller female, probably with the same body build, is one that I've seen, and what I look for is that if she's a shorter statured and she walks a lot, one of the things you see is over lengthening and overextending the hip will irritate the nerve over time and decrease her walking tolerance. Sometimes you need to change their stride length. So I've had success with doing that and improving their ability to walk longer, tolerate standing more by neutral pelvic position. And think about detractioning the nerve. And so that, so you have to look for the right body type, and you get lucky with that. This individual did too, since she had it since childbirth. Basically I've said, well, here's what we can do. We can work peripherally. Let's mobilize the scar, around and under the inguinal ligament. I did that, and I have the benefit of having shockwave here. So I used shockwave on it, and shockwave kind of put her over the top for undoing the scar tissue. So she was pretty happy with that, but 50% better with the changing of the gait and stolid standing and pelvic, and just aligning the pelvis so she wasn't tractioning through the nerve, and the scar tissue, and then either an active release, strong stretch, or some modality intervention, then to break up the scar tissue was one that did pretty well. But that's a specific lesion. This woman has probably a different injury. This is probably a traction style lesion. So she may do well if she's standing or walking or partially changing a bit to get the tension off of it. My guess is with the hematoma, that's the X factor that you can't kind of get over right now. So you gotta get the hematoma down.
Yeah, that's the tough call here, because I wouldn't treat this type of patient with a potential traction injury to the nerve with nerve glides or slides. That just, I mean, essentially it's the same thing as like, we tend to think of the idea that, oh, we need to treat soft tissue injuries with cross-friction massage, right? And so you see all these therapists that get very excited about, they get a bicipital tendonitis coming in, and they just go nuts with the cross-friction stuff, thinking they're healing the thing. But you have to think about the cause of most bicipital tendonitis is impingement. And so you're treating a pressure-induced lesion with more pressure. So the same thing with this, nerve injury is, you don't want to treat a traction nerve injury with more traction, because that was the initial irritant to it in the first place. So what can you do? I mean, there's various ideas that you can kind of have about it. Is there a particular reason why they ended up with, almost like a hinging motion going over that leg? Were they hypermobile in the hips of some sort, where they actually got kind of a pivot there, and the nerve kind of wrapping around where that turned into a pivot point? Was it because, and we're assuming extension, right? We could also have a situation where it actually went into abduction. And that may cause more of kind of that impingement stuff underneath that AIIS, which could be part of it as well. So we're making an assumption there. Now the hard part about trying to do a nerve glide with this is the nerve doesn't even go past the knee. So the only way to really put any traction on is to work with the hip, right? And so at that point, you're basically trying to get them into some sort of prone position in order to stabilize the lumbar component. You may even have to prop them up a little bit, depending on, if this lady, the way she was described is she was obese. So maybe you don't have to worry about that. Maybe her laying in prone doesn't get to full hip extension anyway. And, her body morphology can take some pressure off L5S1. But you don't want to put them into a position where now all of a sudden, as you're sitting there trying to crank on their hip into some extension position to produce a gliding motion of that femoral cutaneous nerve, where you're going to piss off that L5 that's actually giving her shooting pains. So you're better off, because the numbness around the thigh is not a functional limitation. You're better off just letting it be for the time being, and the assumption that it's a traction injury, potentially with a hematoma that has the potential to resolve on its own, because those are self-limiting conditions, right? A traction injury, it should heal eventually. It'll take some time, but it should heal, assuming that there was no rupture to the nerve or any of that sort of thing. And the hematoma should eventually be able to resolve. But you're more likely to cause a worse secondary response by getting over aggressive and trying to deal with that. That's not functionally limiting her, than you would be by just giving it some time and seeing if it will resolve on its own. Now, if it worsens, if the numbness starts spreading down the leg or something of that nature, then you have to reassess. But if you're really sold on the idea that it is a meralgia paresthetica, then yeah, I would just leave it be. If I was convinced it was a traction, extension based, maybe possibly with some sort of hematoma, those things, there's not a ton we need to do with that from a hands-on perspective.
Yeah, that's where I kind of went back up to the lumbar spine. If I feel comfortable with this patient working through that region, I think innervation's anywhere from L1 to L3 with that nerve as it comes off. So one of the proposed mechanisms is spine surgery, where you get this as well. Surgery's in that region. So, if you can create mobility through that region, you probably have dural restrictions, as we talked about in the double crush mechanism going on. So depending on where they are in that continuum, my comfort level with it, was this area doing well with it? I would try and be specific and, just kind of tease through that area. I did do that with patients I've treated, and sometimes I feel like I do see a good result with that, an improved result, and especially if they're stiff and I can get them more mobile. But it's not like the slam dunk one. Don't go to that as the end all be all. But I would do that definitely over probably neural glides or neural tractioning. I wouldn't traction these people because it's a traction injury. Oh, this one I wouldn't traction. Any questions on this case? Or any input or anything you want to challenge, which is more fun?
Yeah, tell me I'm wrong.
Come on, Chris. I know you're thinking it. Come on, say it.
I didn't think so, Chris.
There's two Chris's here, so I figured I'd take a stab at one of them. Figure one of them might bite.
No, I was going to give an example of doing something the wrong way. One time I had a patient with not a similar history, but a similar pain pattern, and the idea was that I thought she had some pain along the femoral nerve tract, and it was using a Maitland technique, but I put her in a little bit of nerve tension and did a joint glide, a graded passive mobilization. It was only like a grade 2+ or 4- or whatever. Wasn't very intense, but it flared her up for weeks. And I thought I was doing something great. I'm like, oh, let's rock and roll. We got this going. We got the pain in your leg while I'm mobilizing it. And I think she was cursing my name for a few weeks. So I was just an example of what not to do. So.
Oh, we all have those.
Yeah. I basically felt like I was just traction at the proximal end or the most central end with doing the mobilization to the spine, because I think I was end up doing traction for both ends and mobilizing. So don't do that.
Good advice. Good advice.
And
Yeah, I mean, I'm flipping through kind of the initial eval stuff here again. I think some of the things that you just got to know, you got to know what's actually fatigable, because I mean, it just says fatigable L5S1. It doesn't tell us what muscles in particular were. Because you have to have at least two to decide that it's going to be L5S1. You can't just test hip abduction and say it's fatigable, because a painful weakness may lie to you, and it may look like a fatigable weakness because it's just gonna start giving out on you. But if you have medial hamstring weakness and hip abduction weakness and hallux extension weakness, then yeah, that's L5, because they're all different peripheral nerves, but the same segmental. So without knowing some of this stuff, it's kind of tough to, get real confident about what's what. But I think Dave's probably pretty right on about this, that there was an initial injury and then complicating factors when she went back to work and things started changing a little bit. So, it's just about, for me, when you're into these cases and things kind of seem very vague, it's about finding where some of these functional restrictions are, what's limiting this person from a movement perspective on what she needs to be able to do during her day. Like, we know that she needs to be able to, move from side to side. She needs to be able to lift some things. She needs to be able to stand for prolonged periods. So where are we going to be able to improve that for her, right? So TL junction for rotational stuff. Probably could look at the fibular head, fibular base for being able to pivot. We've talked about being able to do these standing axial rotations that are not just thoracic movement, that actually go through the pelvis, that go through the lower leg. That's an area where we may be able to improve some things from that and into the foot and the ankle. What does the subtalar joint move properly? So you can unload this patient from top to bottom. It's just a matter of where you find these restrictions. For the L5S1 stuff, how are we going to be able to improve any of these potential anterior shear mechanisms that are going on with her? Does she have a stiff hip? She's in her mid-50s, obviously just had a trauma to it. Decent chance that she's kind of working in a flexed hip posture, particularly if she has some traction injury to one of the nerves going across the front of the hip. Odds are she's going to kind of slouch forward to protect that sort of thing, right? So, and honestly, if she had a traction injury to the lateral femorocutaneous nerve and it was significant enough to cause potentially a hematoma, the odds that this patient does not have some structural damage to the rectus femoris or any of that anterior femoral triangle musculature, is so slim, because what would have caused the hematoma? Something had to have started bleeding, right? So there's some sort of damage to that as well. So she may be flexing to try and avoid that. So alleviating that pressure again is that's just where you can go. You just have to kind of look at it from a perspective of, this is what the patient needs to do, you know, functionally. They have to be able to produce this motion with their body or absorb this load with their body. How can I improve that for them? Okay, let's look at this area. Let's look at that area. Let's look at this area. So, you know, you guys know enough about this, you know, particularly the two of you that are still on here, to look at a patient and say like, oh yeah, this is their, you know, meaningful task to, you know, steal something from Diane Lee. And I need to look around in their body to see what other areas here help produce that task. And if I can find limitations in any of them, then by improving those, I should be able to help that patient. Anyway, that's where I'm at.
I think that worked pretty well. It was a good case. There was enough vagueness in it to kind of think through.
Yep, that was an interesting one, for sure.
Yeah, I'm curious to hear how her treatment goes today.
Yeah.
I'll kick it over to you.
Okay.
If you want to, I'll send it out just on a group text or group email.
Sure.
I'll follow up on it.
Well, and we can always talk about it more next week too, once she has a chance to kind of digest what she's doing. Maybe she'll have seen the person more than once since then too.
Yeah.
So
Thanks a lot, guys. That was really good, detailed discussion. I appreciate that. I think that's a challenging patient for anybody.
Yes.
So.
Sure. And especially when you think about the fact that the patient's overweight, it's just like, well, how do you even get into some of these areas and to begin with? It's tough sometimes, right? You know, saying like, well, I need to examine the anterior hip here, and you're looking at it like, you know, how do I even know what I'm getting my hands on? Sometimes that can be hard stuff, you know. So yeah, it's a challenging one for sure. Better her than me.
Yeah. All right, guys.
All right.
Do it.